Very good morning to all of you. The topic that we are going to discuss today is an introduction to dental implants, the types of implants, and the implant biomaterials. There are many options available with us to replace missing teeth. When one or a few teeth are missing, they can be replaced using removable partial dentures, fixed partial dentures, and when all the teeth are missing, we can use complete dentures to replace this missing teeth. But are these the best options? You all know very well that implants are the latest option for replacing missing teeth. What are dental implants? They are metal posts or frames which are surgically positioned into the jawbone beneath the gums, and once in place, they allow us to mount replacement teeth onto them. Implants can replace one or more teeth without affecting the adjacent teeth. They can support crowns or bridges and eliminate the need for removable prosthesis. They can support even complete dentures, making the dentures more secure and more comfortable and easy to use for the patient. They can provide anchorage during orthodontic tooth movement, and they maintain the height and the width of the alveolar bone. A dental implant is defined as a material or a device placed in and or on oral tissues to support an oral prosthesis. The latest definition, the Glossary of Prosthodontic Terminologies, edition 9, defines an implant as any object or material such as an alloplastic substance or other tissue which is partially or completely inserted or grafted onto the body for therapeutic, diagnostic, prosthetic, or experimental purposes. Let us take a brief look at the history of dental implants. Do you think these implants are a recent innovation? Definitely not. Ancient Egyptians, as early as 2500 BC onwards, used a number of materials like shells, ivory, wood, etc., and wedged them into the alveolar bone to simulate teeth. Gold bands, which had artificial tooth or natural tooth incorporated into them, were found around 500 BC onwards. Many such instances of materials being used as dental implants have been unearthed from archaeological finds and other sources. But it was Dr. Per Ingvar Brannemark, a Swedish physician, who developed the concept of the modern dental implant. And he is known as the father of modern dental implantology. Let us take a look at the different types of implants that are prevalent in use today. Dr. Charles Babbage has classified implants based on their location or position in which they are placed as subperiosteal, endosteal, transosteal, and mucosal. Subperiosteal. The name itself says that these implants are placed beneath the periosteum in the mandible. Okay, it covers the almost the entire crestal surface of the maxilla and the mandible under the soft tissue, under the periosteum, and there are 4 to 6 posts which protrude out through the gingiva, and a complete denture can be attached to this. Okay, it is placed much like a saddle on the back of a horse. It rests upon the bony ridge. It does not penetrate the bony ridge. The endosseous implants penetrate one cortical plate. They are partially submerged and anchored within the bone. They can be of different shapes. They can be the blade type implants, the cylindrical implants, the screw type or hollow implants, or the most recent, the root form implants. The endosseous and or endosteal implants were first placed by Strock in 1939. It is a dental implant which extends to the bone for support but transects only one cortical plate. Whereas The transosteal implants, the name itself suggests that they run through the entire bone. Okay, they penetrate both cortical plates and passes through the entire thickness of the alveolar bone. Therefore, they can be placed only in the mandible. They emerge out from the opposite side, usually at the bottom of the chin. They're also called the staple bone implant, the mandibular staple implant, or the transmandibular implant. The mucosal implant are transitional or temporary implants which penetrate only into the mucosa and can provide anchorage or retention to a prosthesis for a short period of time. Now, before we proceed further, let us take a look at the different implant components. An implant prosthesis consists of the implant fixture, abutment, and crown. The implant or the implant fixture is that portion that is placed inside the bone. The abutment provides a connection to the implant and to the prosthesis. And the prosthesis can be either a crown or a bridge or even a denture which is screwed onto the implant. How does this implant get connected to the bone? We all know we are surgically placing an implant inside the bone. Is there a connection between the implant and the bone? There are two basic theories for that. The most popular theory is the theory of osseointegration proposed by Dr. Per Ingvar Brånemark in 1985. The other theory is the fibro-osseous integration proposed by Linkow, James, Weiss, etc. Let us take a look at the concept of osseointegration. Like I said before, it was developed by Dr. Per Ingvar Brånemark, who was a professor at the Institute for Applied Biotechnology in Sweden. When he was studying the microcirculation in rabbits, he used vital microscopes which were placed inside titanium chambers, and they were impregnated into the femur bone of rabbits. He was not studying implants. He was studying the microcirculation in rabbit femur, and he used the vital microscope. And to place this vital microscope inside the bone, he used small titanium chambers. After a period of time, when the rabbit was sacrificed and he was trying to recover this vital microscope, he found that these titanium chambers had become firmly adherent to the bone. He could not separate the bone and remove the titanium chambers. Then further studies showed that this titanium could become so fused with bone that the two cannot be separated without fracture. With this, he developed the concept of osseointegration. Osseointegration is defined as the apparent direct attachment or connection of osseous tissue to an inert alloplastic material without any intervening connective tissue. That is, it is a connection of an material and bone such that there is no connective tissue in between them. In opposition to this is the theory of fibro-osseous integration, which is defined by the American Academy of Implant Dentistry as tissue to implant contact with interposition of healthy, dense, collagenous tissue between the implant and the bone. They say that this collagenous tissue acts as a shock absorber. But now the more accepted theory is a theory of osseointegration. That is the direct connection of implant and bone without any tissue in between them. And the period required for an implant to osseointegrate can vary from anywhere between 3 to 12 months, depending on several factors like the bone quality, quantity, how the surgery was done, and the type, shape, number of implants, and depending on any diseases, systemic diseases the patient could have, etc. So let us take a quick recap at what we have seen now. We know what an implant is. The different types of implants are the subperiosteal, endosteal, transosteal, and mucosal implants. An implant has three main parts: the implant fixture, which is placed inside the bone, the abutment, which connects the implant to the prosthesis, and the prosthesis, which can be a crown or a bridge, etc. We know what is osseointegration and what is fibro-osseointegration. What we need is osseointegration, that is the direct bonding or fusing of bone to a dental implant. I told you this osseointegration depends on various structures, and one of the key factors in that is the implant material. So the implant must be composed of a material which will allow easy and fast osseointegration. Let us take a look at the different implant materials which are used for making implant fixtures, which are used for coating the surface of implants, and which are used for making the different implant abutments, screws, etc. An implant material is the material used in the fabrication of implants and implant components. Based on the biological properties of these materials, they can be classified as biotolerant, bioinert, and bioactive. Biotolerant materials are those materials which are just tolerated by our body. They're not rejected. A fibrous capsule forms around this material and they are held in place, but they do not actively promote bone formation, or they do not necessarily allow bone formation. Bioinert materials allow the formation of bone on their surface, and it leads to a process which is called contact osteogenesis. That is, bone directly forms on the surface of these materials, but there is no chemical exchange of ions between the implant material and bone in that. Bioactive materials are materials which allow formation of new bone on their surface, and they have an ion exchange with the host tissue, and a chemical bond forms at the interface. This is also called bonding osteogenesis. This rapidly promotes osseointegration and is a most desirable property in implant biomaterials. According to the basic materials, implant materials can be classified as metals, ceramics, polymers, others, and surface-coated titanium. Let us take a look at the different implant materials that are available today. According to the biocompatibility, implant materials are classified as biotolerant, bioinert, and bioactive. The biotolerant materials which we have in use are metals like gold, cobalt, chromium alloys, stainless steel, zirconium, etc. The most important of this is the tantalum and niobium. There are no biotolerant ceramics. All polymers are biotolerant materials. The bioinert metals which are used most commonly today are titanium and its alloys. Bioinert ceramics like zirconium oxide and aluminum oxide are also used. Ceramics are basically bioactive materials which promote bonding osteogenesis and rapid osseointegration with the bone. Many bioactive ceramics like hydroxyapatite, TCP or tricalcium phosphate, calcium pyrophosphate, fluorapatite, bioglass, and carbon are used nowadays. The most common implant material is a bioinert metal, which is called titanium. Titanium is used in two different forms: the commercially pure titanium and a titanium alloy, that is titanium 6 aluminium 4 vanadium. They are chemically pure. They have an ability to form a passivating oxide layer on them on exposure, okay, which forms at the rate of 100 Armstrong thick layer per minute. They are highly biocompatible and corrosion resistant, and they have a lot of desirable physical and mechanical properties. They can readily osseointegrate, they are bioactive, and they promote the formation of bone in direct contact with the metal surface. The commercially pure titanium is available in 4 grades from grade 1 to grade 4 based on the amount of oxygen, nitrogen, hydrogen, iron, and carbon present in them. The commercially pure titanium is also called unalloyed titanium. It has a stronger bony interaction with better osseointegration. The titanium alloy, that is the titanium 6 aluminium 4 vanadium alloy, is, however, stronger than commercially pure titanium. Ceramics can be bio-inert ceramics like carbon, zirconium oxide, or aluminium oxide, or it can be bioactive ceramics like TCP, hydroxyapatite, calcium pyrophosphate, fluorapatite, and bioglass. Ceramics and carbons are biocompatible, high-strength materials, but they are inherently brittle and have very low ductility. Calcium phosphate ceramic has a composition which is almost very closely similar to bone. The color is also similar to bone, and this is generally used as a coating over metallic implants to make the metallic implants bioactive. Hydroxyapatite again has osteoconductive effect when it comes in contact with bone, and again they are used as coating on metallic implants. Zirconia implants were introduced in the European market in 2011 and are widely used as implants in the anterior region. They can be used for endosteal, root form, or plate form implants. They have a clear white, cream, or light gray color, and they can be used in the anterior region where the bone is thin. They have minimal biodegradation, high modulus of elasticity, but low fracture resistance. And they also exhibit direct bonding with bone. Polymers and composites like polytetrafluoroethylene, PTFE, then polymethyl methacrylate, polysulfones, silicone rubbers are also widely used. Polyether ether ketone is an organic synthetic polymer material which was first developed in 1978. It is a semi-crystalline, linear, polycyclic thermoplastic material, and it has been proposed as a substitute for metals in biomaterials. PEEK can be used in dental implant biomaterials as an implant superstructure, an implant fixture, or implant abutment. It has a light gray or a cream color, and they're used as implant abutments mainly in the anterior region for better aesthetics. Surface coated titanium. I told you titanium is one of the most popular biomaterials used for implants. Titanium, however, is a bio-inert material. To make the osseointegration with bone better, so different surface modifications have been done on titanium to increase the surface area so that osseointegration can be better. The first modification done to titanium is the acid etching of the surface. Acid etching is done with a solution of hydrochloric acid and sulfuric acid, which imparts a surface roughness to the implant, improves the surface area. A rougher surface also allows better and faster osseointegration in bone. This also cleans the implant surface. SLA is a technology which incorporates sandblasting with large grit 250 to 500 micrometer corundum and acid etching with a solution of hydrochloric acid and sulfuric acid. It imparts micro roughness to the surface of the implant. It cleans the implant surface and allows better osseointegration and a larger surface area for osseointegration. One of the most commonly used surface modification is the titanium plasma sprayed coating, also known as the TPS coating. This technique involves forcing noble gas, which is usually argon. This gas is split into electrons by passing it through an intensely burning arc at a very high speed. Now, the coating material, which is usually titanium hydride, is fed into this gas spray. The titanium hydride decomposes and forms very small droplets of metal, which are shot onto the surface of the implant. They coat the surface of the implant, forming small droplets of titanium on the surface. They provide micro roughness to the surface, also increase the surface area of the implant. 6 to 10 times increase in surface area of the implant can be done using this process, and the surface roughness also increases to 6 microns. So we come to the end of this lecture. We know the different types of implants are the endosseous, subperiosteal, transosteal, and mucosal implants. The different components or parts of an implant are the implant fixtures, abutments, screws, and the implant crowns or bridges. Implant materials can be classified according to their biological properties as biotolerant, bioinert, and bioactive. We desire bioactive materials for better osseointegration. Implant materials are also classified as metals, ceramics, polymers, and surface-coated titanium. Titanium is the most commonly used material. Titanium is a bioinert implant material. Several ceramics like the tricalcium phosphate, hydroapatite, etc. are used as coatings on the titanium surface to make the bioinert implant bioactive, because we always prefer osseointegration over fibro-osseointegration. So with this in mind, we come to the end of this lecture. Thank you for being such a patient audience. Thank you.